Good evening, members. Welcome to our IDS webinar. So a few months ago, I offered an hour free consultation call with some of the office managers of our members so that I could gather some of the top barriers that they face in the office and give them solutions and share those solutions with you. So one of the ones that we had is what we're going to show tonight. It's about 40 minutes. And these barriers, I think that you're going to relate to some of the common barriers that your front desk has.
You know, I see the first one, it says insurance barriers. And I know everybody, there's an awful lot of...
You know, with the insurance barriers, funny that you say that, because of all the free consult calls that I did with these office managers, they all had the same one. So we did cover insurance barriers with every single office that I talked to, and they were all different types of questions. So, which is great, I think, because it always seems like prices, quoting fees, presenting treatment plans, asking for money, and insurance barriers tend to be the most popular ones. So yes, this one is a different type of insurance barrier that we're going to be going over. The other one is paying before the day of surgery. Yeah. Can you imagine that?
Yeah.
Paying?
How can you not?
There's still offices out there, yes, that collect the day that they come in.
I know, and
I don't get it.
Same with the insurance barriers.
Yes.
You know, we stopped taking insurance. Well, we really never really took insurance, but our practice continues to grow without insurance. And it's only the skill level. It's only the skill level of you and your staff in doing presentations.
Yes.
There are plenty of patients out there. But if you're dependent upon the referral source who also takes insurance, I understand you've got insurance barriers. Yes. If you're comfortable doing that, that's fine. But it doesn't have to be that way. It doesn't have to be that way no matter where you are. I don't care what part of the country you're in.
And these barriers that we do cover, most of them are offices that do accept insurances and that do work with general referrals. So you will be able to relate to these. So paying the day before surgery, we actually pay 2 weeks. We have them pay 2 weeks before the surgery. So paying prior to arriving for their surgery. The next one is check in and out slips. And this is something that we came up with a while ago that really helps the flow, the communication from the front to the back. Because there always seems to be this front versus back type of thing that happens in offices. And this does really help with the communication and the flow.
And we found the same thing until we did the same things we're talking about.
Yes. So it's a great idea that you guys can implement tomorrow on how to increase that communication. The other one is doctor hygiene visits. That's a big one too. You're always being taken away from production, from new patients, from surgeries, to run and do a hygiene check. So how do you go about with those? What to do when the doctor's behind. That's a big one. So it was asked, what do we do when the doctor's running behind in surgery? What do we do? I'm going to tell you what to do with that. Maximizing the surgery schedule. So of course you can maximize your production. Training new assistants. So what do you do when you're training a new assistant for your practice and you want to be sure that it flows well with the doctor, that it doesn't interfere too much with the other assistants, so it's being bogged down. How do you get it to where from day one they can start doing things to contribute and actually start helping out the team? When the patients don't want to go back to the general dentist that referred them to your practice, what do you say? What do you do? Because we get that a lot. Can I just do it all here? Do I have to go back? I don't want to go back to them, but they referred them to your office. So be careful with that one. So we talk about that one a little bit. And then the next one is just financing companies, different ones that you can look into. We chose there's probably about 3 or 4 of them out that we talk about on the video, but we use 2 and they work out very well for us. So going over different options that your girls can use for financing.
Good. So let's show.
Enjoy.
The show. Play the audio.
Mm-hmm.
First one that you have, which has a lot to do with the insurance, because we're not
Let's try that again.
Insurance providers. I can't give you too much information on that. I don't really know about the accounts receivables and the resubmitting, because for us, we just submit as a courtesy and then we're done. That's all we do.
Yeah.
So how many insurances do you take? How many insurance companies do you work with?
So we're only contracted with MODA, and we're premier providers for them, and that's it.
Okay. So for the rest of your patients, it's just
we're all they would all be out of network. I mean,
okay.
they still submit everything to their insurances, but we are considered out of network for their insurances, which I like to make sure patients know.
Got it. So the biggest problem that you're having is just with that one insurance company?
Well, it's not even with MODA. It's with all of the other insurance companies that we're submitting to, you know, sending claims in, and then they process them incorrectly. And, you know, we have claims that are almost a year old that still haven't been paid out on.
Yeah, now that you know, we do have the same thing that occurs with us. And, you know, the same thing I say with our patients, because it's true, is the insurance companies, they don't want to pay the money. It's not like they're ready to just send that check out to you. But we do, what we started doing was we started to send the patients a copy of what we're sending the insurance companies, and then send the insurance companies. And we say, listen, we do this because it is consistent that the insurance company is going to send you a letter back, and they're going to say, we don't have a photo, we don't have an x-ray, we don't have perio charting. They're going to say they're missing stuff. So we're going to send you a packet of what we're sending them. That way, if there's a problem, you have it right there. You can talk to them and say, hey, I have a copy of what they sent you. Or you can just send it on, you know, right away, whatever you want, because we send it as a courtesy because it's easier for us, it's faster for us. You know, we know the lingo, whatever, we send it. But it seems like they will deny it 1, 2, 3 times, saying that we don't have something, and then they'll end up paying it. It's like a game that they play because they're trying to drag their feet on it, or hope that you're just going to say, forget it, you know, I'm just going to forget about it. But, you know, we do resubmit every time they ask us. We just play their game and do what they say.
Yes.
The pain in the butt, but we do it.
Yeah, and I've had a couple of claims where I've sent everything to them, and then I call and they say they've received it, but then when they check on it, they process it incorrectly, so it has to be reprocessed again. And then I'll call and they processed it incorrectly again, so it needs to be resubmitted again. And so
they're dragging their feet, and they're making it frustrating to the patient. I always, you know, give the patients a heads up on that. You know, when I first send it, you know, we do a courtesy call them and say, listen, you know, just don't be discouraged when this happens. It's a typical dental insurance game that they play, you know, and we're going to keep resubmitting every time they ask us. We're going to do it. My question for you, though, is, are you not collecting the full fee up front? Are you only collecting partial payment or something?
That's correct. Yeah, so we're only collecting what we estimate the patient portion to be, and I always let the patient know, you know, could pay more than what I'm estimating, but they can also pay less. So if they pay less, then I'll send them a statement for the difference. If they may pay more, I'll send them a refund.
Got it. Well, I will ask you to consider this new policy because we have never done it like that. We do not accept any insurance. We're not a provider for any insurance. So we say probably exactly what you say. We're not a provider for your insurance company. We're actually out of network. But we will, out of courtesy, we will submit all the paperwork and we will try to maximize your reimbursement. However, because of that reason, the full fee is expected 2 weeks prior to the surgery or the treatment plan. We cannot submit this claim until the procedure is done. I don't know how it is for you, but in the state of Florida, we cannot submit it until it's been done.
We can't submit it.
Right. So then I say the day we do the surgery, we're going to submit all the x-rays, photos, dictations, charting, letters, everything to maximize your reimbursement. And then they're going to send that reimbursement check to you, which we make sure it happens. Now, if they accidentally send it to you guys, of course, you can give it to her. But I say then they will reimburse you the amount that's covered on your insurance. So with confidence, we explain that to them because we are talking about anywhere between $1,000 and $2,000, depending on what their benefits are. And so I say to them, you know, you will be able to, whatever your insurance company is going to cover for you, they will send you back that as a reimbursement. So
how do your patients take that when you're asking them to pay in full and also 2 weeks prior?
Okay, I have never had a patient get upset with me, but they have questioned it. They'll say something like, and that's where the confidence thing comes in on your tone, is I have some people here in my office that I won't allow to do financials because when they answer that question, they're like, well, I know, and yeah, I know. It's kind of like you're making it sound like it's a problem and it's a pain in the rear, but if you can answer it like, for example, if they say, gosh, I have to pay for that 2 weeks before. Yeah, we do require that to be paid 2 weeks before. Now, that's a problem. We do, you know, I can stretch it to a week before, but The reason why is because we have to order the materials, we have to have the implants, everything in stock, and that is how we confirm the appointment, by having full payment. So I always get that 1 week prior. For the insurance thing, I don't ever get someone mad about that. They will, of course, question. They'll say, "Oh, I have to pay all of this? You don't take, I don't get, I can't get the portion that my insurance covers out and then pay the rest." No, yeah, that's where that out-of-network thing comes in. We're not a provider, so we do have to collect the full payment prior to the surgical visit, which is, 1 to 2 weeks, however you want to do it, before the date. But when they do give you the reimbursement, they are going to send that right to you. And, it's an insurance company, so I wouldn't expect it right away. At least 3 weeks, but up to, 8, 9 weeks after, before you would expect that. And that's where I also say, sometimes it's an insurance game as well. They may send you an IA letter saying that they didn't get something, but we keep on resubmitting that for you until they send you back that reimbursement. And then I don't, of course, leave too much of a pause between answering that question and going, okay, so your surgery is going to be on April 19th. You're going to be in at 7 o'clock in the morning. I just proceed, because if you keep proceeding with them on that's just the way it is, it's a normal for us, it's a normal in the world, it's just the way things are, they're okay. And like I said, with those staff members that I won't allow to do financials, it's almost like they put their personal self in that situation where they would be really, disappointed and maybe in a pickle if they were presented with that same scenario. So they can't answer that question without feeling bad. And in the moment you start feeling bad, they start thinking, well, then if she feels bad, I guess it's not right.
That's not right. Yeah, no, I definitely agree. Well, when I started here end of September, and the front office and the office manager weren't collecting anything from the patient.
Yeah.
Like when they were coming in, they were just leaving it up to insurance, have insurance pay, and then whatever insurance paid, then they would send the statement to the patient for however much they owe. And so now, I have to deal with $130,000 accounts receivable.
Oh my goodness.
I'm trying to collect.
Yeah. It's so much easier to collect it up front, because you know what? In the beginning, they're excited about treatment. They're excited and they want to have it done. And, afterwards, you can find all kinds of reasons why you can justify you shouldn't have to pay that money. It's done.
Yeah.
So yeah, absolutely. When we do our new patient examinations, we present them the treatment at that time. Without insurance. Insurance is just not involved in the equation. I present them the fee of how much it's going to be. It's going to be $13,000 to have this done. We're going to collect, that needs to be paid 2 weeks prior to the surgical date. Your surgical date is, June 19th. So this needs to be paid on or before this date right here. If you do want to prepay for that, we do offer a 5% discount to prepay for that, which will save you, whatever amount of dollars for that. Or if you would rather have payments, we have Care Credit. They offer 12-month interest-free, or they have interest-bearing payments if you want something smaller. It's up to you. Which one of those is more comfortable for you? That's probably where we're going to get the insurance question. Well, my insurance, what's my insurance going to pay? Well, the insurance is a separate entity here. As we said before, we are out of network. So what we do as a courtesy is the day that you have the procedure done, we file the insurance so they can reimburse you. We can't do that until it's been done, because the insurance company wants to see it's been done. So the day you have your procedure, we're going to send all this to the insurance company, and then they're going to reimburse you what it is they cover. All right? Okay, so then carry on. Keep going. So they have to
do that with cleanings as well?
No, not with cleanings. Cleanings we have them pay when they come in.
You don't have them pay when they come in.
Correct.
Like they pay for the whole cleaning, even if they have insurance, and then you submit it to insurance, and then they pay.
Absolutely. They pay $164 when they come in for their cleaning, and then when they ask about their insurance, which even if they've been here 50 times, they always ask us, what's my insurance going to cover? We're going to submit that for you today, and they're going to send you back whatever the reimbursement is. So, yeah, same exact thing.
Okay.
So I know for you guys,
we've always done it that way, though, too, right?
Correct. We've always done it that way. So your biggest frustration is going to be the ones that are used to it. If you guys want to keep doing it for patients that you have been doing it for and they pay and they're not a problem, that's fine. You can start doing it with the patients that don't pay, the ones that are a problem. Just to say, we do have a problem, collecting that, whatever it is, they are the ones that are not compliant. So of course, those are the ones that you want to change the rules on. If you have a compliant patient that does it that way, we do make special arrangements for patients that are really good like that. So, you can keep it the same for them. But for all new patients from here on out, I would change your policy for that.
Okay. Yeah, I like that.
Well, good. I was able to answer that question. Good. All right.
No, I like that a lot. I mean, a lot of things have changed since I've started here because I'm like, you guys have to collect. We have to collect when the patient's here. But, I mean, obviously we're not collecting the full amount. I'm just collecting,
right.
what we estimate the patient portion to be.
Right. Got it. Yes. So yeah, definitely will save you a lot of paperwork by collecting that. That's, and that's why that's where that 5%, and we go up to 10% because to be honest with you, Care Credit is going to give you a 10% hit if they choose Care Credit. So you may as well give them a discount. You're not really losing out. That's where that discount comes in because they feel like they're getting something, And I say that's why we give you a 5% discount. We're trying to make up a little bit here for where the insurance company is kind of letting you down. So if they prepay, that saves us a ton of paperwork. It's done, it's paid for, and we don't have to worry about that again.
Mhm. Yeah, I like that.
Good. So your next question that you had was communication in the office. What kind of problem are you having with that?
So a lot of the time, the assistants will come up with a patient and just kind of drop them off, and so then we are left wondering, what are we needing to schedule them for next, or, just what's the next step. And so we're having a lot of communication issues that way, and also between, if the hygienist is seeing a patient and the doctor needs to do an exam, just like having the hygienist and the doctor, talk about what's going on with the patient before the doctor's coming in. So just we're just having a lot of communication issues.
Okay, so for the first problem that you have, what we do in the office, because we've had the same problems here. What we started doing is the receptionist that checks in the patient, hi, Ms. Smith, how you doing? You can have a seat. Jane will be with you in a second. She starts a sign-in sheet for the patient that all it is a small slip of paper, and it has the patient's name, it has the date, it has on there a line that says next visit is. It has a line on there that says today's balance due is, and then she leaves that on her counter so that when the assistant comes to get the patient, she grabs that slip, takes the patient back, and then when she brings the patient back up to the front desk to check out, she has to leave that slip. A few reasons. One, sometimes the assistant doesn't have time to stand there and explain to the receptionist. They're behind. They got to run. That's actually most of the time here. So the assistant can bring the patient up to the front desk, lay the slip on the table, and say, Jane, have a great day. We'll see you back in a few weeks or whatever, and then she leaves. Now the receptionist can take the slip paper and says, oh, in 2 weeks she needs to come in for a try-in. It has on there how many units or how much time, 1 hour with the doctor, 15 minutes before with an assistant, 15 minutes after with an assistant, whatever. So it's broken up in assistant time, doctor time, setup, cleanup time, however you guys have it. And then it has on there what it is, and it has on there how much is due today. So Lisa, my receptionist, can confidently say, okay, looks like here you need to come back in 2 weeks for this appointment here, and today's appointment is going to be $85. So it's there's no confusion whatsoever. And we started doing that, and the new rule was we are not going to check out your patient until you bring us that slip, because we can't just run around the office and find out what's going on. Or when the patient leaves, the assistant comes back and goes, you didn't collect the money? Well, what money? What are you talking about?
Yeah. Yes, exactly.
So I would recommend that you guys design that same kind of slip and make it a policy where it's a good communication piece. It gets passed around from the front desk to the assistant, back to the front desk, and everything is on that paper.
Yeah, well, we have a routing slip or a care slip, but a lot of the times, same thing. It doesn't get actually brought up to us, or it just gets filed away without ever reaching our hands.
Correct. Right. So for Lisa, she's had that same problem before. I told her, I said, it's going to be a little uncomfortable and frustrating at first, but you're going to have to get up, go find the assistant again and say, I need this filled out. And me as an office manager, I had to get a little meeting together and say, listen, I've told Lisa she is not allowed to check out these patients without that slip, because it just causes so much, so much frustrations for us and errors for us. I just need to fill out this piece of paper. What is the next visit? How much time do you need? When do you need it? When time frame, give me a time frame, and how much is due today? That's all I need. So a few times she did have to go find that assistant. I'm sorry, but I need this filled out or I can't schedule the patient. And of course the assistant, huffs a little bit, fills it out. And I can say, listen, I'm sorry, but, we really do need this paper. And then eventually they all brought it because they didn't want us to go find them, and they saw paper.
Yes. Yeah, hopefully eventually it becomes habit where they just...
Yeah, it will. And that's where the consistency thing comes in. I hate, using, the reference on it, but it's like kids, if they feel like it's okay if they don't do it every once in a while and they don't understand the importance of it, they're not going to do it. So you have to be really consistent on, if you don't bring it up, we can't schedule your patient. And that also helps us with making sure that transactions were put in and notes were put in, because it made it to where now she kept these slips, and the receptionist was able to look back to check to make sure that transactions were put in and notes were put in, and she was kind of like my quality control check, and she would give me the slips and let me know, hey, next visit wasn't put in, hey, notes aren't put in, and I can see the inaccuracy in the slips because I'm checking them, and I could go back to that assistant and say, hey, look, these are your slips here. I know you can do this better. Can you just help us out and give us the information that we need? And that usually is where I was able to nip it.
Mm-hmm. Perfect.
Good. And what was the other one you said on hygienist?
So the hygienist sometimes, like if they're doing a cleaning and the doctor needs to see them for, an annual exam, the hygienist will the hygienist will have an assistant move them over into doctor's room and then just never go and talk to doctor, about what's going on, with their cleanings or, where they think that they're at. So just the same thing with communication, just not communicating because they've moved on to their next patient.
I see. Our annual hygiene checks are done in the hygiene room. So usually we can identify prior to the patient coming in. It can be designated on the schedule if it's with a doctor or without, but that it doesn't always work out that way. So I don't know how much time you give your hygienist. We give our hygienist an hour to do their cleaning. And
we do an hour 15. So
okay.
Yeah.
Okay. So within that time, it's up to them to put their light indicator on, their call button, whatever it is, or let somebody know, hey, Jane is here she has to see the doctor today for an annual, and whenever she gets to her point where, for example, probing is done, which is really what needs to be done before the doctor comes in, that way they can talk in front of the patient. So she will put her light on or her indicator on. I need a doctor in room 3 for hygiene check. And then when he comes in, she is still working on the patient. Doctor's washing his hands. Jane, it's been a year since you've seen Jane. We did probing today. Everything's within normal limits. I don't really see anything, going on. She does have a concern about a little bump here. So she's talking to the doctor in front of the patient. He sits down, he takes his look, and then he leaves. It's so much faster that way.
Mm-hmm. Okay. Yeah, I agree. But that comes into the same thing. It's like I have another little point on there, running behind for appointments. We are constantly behind.
Yes.
And I don't know where we go wrong.
Well, if they are running behind, is your policy 1 year, doctor check every single year?
Yeah.
Okay. So if
sometimes we'll just have to bring them back.
Yes, that's what we do. If they're running that far behind, we do schedule them for a quick reevaluation with a doctor for the same amount of money because we charge $35 for a doctor's check. So we go on ahead and charge them that day and just say, in 2 weeks or 1 week or tomorrow, come back in for a quick doctor check, and then we do that doctor check, on a separate appointment. I hate doing that because it does inconvenience the patient to have to come back again. The other thing we sometimes do is at the hygienist's discretion, if it's a patient that's just never had a problem and she doesn't see any problems at all, we do go on to the next year. If they're a 1 year patient, it does look good. And then she will give that communication to the doctor by the end of the day, like a note in his box to say, Jane Smith was in today. You can take a look at her bite wings. I didn't see any issues going on. She doesn't have any complaints. We were behind today. You didn't get to see them. Is it okay that she comes back next year for the duct check, or would you like her to come in sooner than that? Okay. Most patients don't come in once a year. Most patients come in at least twice a year, sometimes more. So we can catch them a little bit sooner than a year for a doctor's check. We just kind of tail it on the next one.
Okay. And how do you guys go about, like, just running behind on surgeries or, you know, new patients, or, like I said, we're constantly like an hour.
Well, I can help you out best if I were able to sit down with you and see how you're scheduling. So I can't answer that the best without looking at what you're giving the assistants for setup and cleanup to turn over a room, what you're giving doctors, of course, for their time frame and so on. So I can just tell you how we're doing things, and maybe it will help you a little bit. So we have first thing in the morning, what we typically do is we usually see a new patient right off the bat, because it's something that's very predictable. So he comes in at 8 o'clock. He has to be dressed, ready to go at 8 o'clock, because the new patient exam starts at 8 o'clock. Comes into the new patient examination. He has till 8:30 to do that examination. So it's up to the assistant to make sure that everything is done, data collection is done, that doctor is in that room at 8 o'clock. He's done at 8:30. He's due at 8:30 to go into the first surgery. So it's like he goes from that room to the next. So the surgery, let's say he's in there for 2 hours. If he's running behind, and we don't give, extra time in between for the doctor. If he's supposed to be out of that surgery at 11 o'clock, his next new patient is waiting for him at 11 o'clock. So, we do that to maximize our production. So he is supposed to be out of that surgery at 11 o'clock, and then he goes into the next patient at 11 o'clock. If the assistant, the doctor, can identify that they're running behind early, of course, I have them give the front desk some kind of notice. I don't know how you guys do your communications, your calls, or how the surgery can communicate. But usually we call in for someone to come into the surgical room. Hey, we are running about 30 minutes behind. Hey, we're running about an hour behind. That way we can let that patient know, the schedulers up front know, bump everything down 30 minutes. We're running behind, because I don't want the rest of the day to fall apart. So we are more or less moving the entire schedule down 30 minutes for the rest of the day. If it's something where he's just running 30 minutes behind, we don't know that until 11 o'clock. He's trying his hardest to get through, which is usually what happens. Then we are just simply running behind. So we're doing something with the patient that's waiting for him. My rule for that is don't leave a patient in the room by themselves. Sit there, talk to them about your kids, your dogs, your week. I don't care. Just sit there and talk to them. Don't make them just look at the wall, because it makes it so much worse. So then we have the doctor get in there as fast as he can. Usually he can make up for the time. Usually he can just do, less socializing, whatever it is. And if we tell him, listen, you're 30 minutes behind, he can usually make up for it by just, kind of hustling for us. As far as if you can pinpoint what it is he's getting behind on, or if you can identify it's not him that's running late, it's the assistants not being ready for him. So what we did on that was we started designating cleanup setup times before and after appointment. So when a surgery is over, we give them 20 minutes to clean the room, turn it over for the next room. And prior to a surgery, we give them 20 minutes to set up a room. So we have kind of 20 minutes on the beginning and ending of every surgery to give them time to completely turn everything around and get it ready. Okay. As far as reevaluations or new patients or something, we do give them 10 minutes between each patient to same thing. Check out your patient, get back, turn over the room, reset it up, and get your patient back. Because if you don't give them the cleanup and setup time, it's really hard for them to be able to go to the next patient, for one, error-free, because they need to get everything, in the computer, on the charts, whatever it is they're doing, to complete that cycle of action before going to the next one. So it just helps us staying on schedule by putting that buffer time in for the assistant to get everything ready to go. Because usually it is the assistant, not the doctor. He's waiting on us.
Yeah.
Okay.
Yeah.
Does that help you there?
Yeah, it does. How many assistants do you guys have?
We have 3 assistants per doctor.
Oh, per doctor. And how many doctors do you have?
We have 3.
Oh, you have 3 doctors.
Yeah.
Okay.
But they don't go into each other's departments. So surgical is surgical, restorative is restorative, new patients. So the advice I'm giving you is the advice on one doctor though. It's when it was just Dr. Sheldon here. Yeah, and that's all we did. So that's how we ended up doing things for him, because even if you have the cleanup setup time, he can go with another assistant somewhere else. You know, when he walks out of that surgery and he goes into somebody else's surgery, my assistant ending that surgery can discharge that patient, clean that room, get it all reset up for the next one. So when he's done with that next surgery, he's going back into that room. It's ready to go. So, you know, you need at least 2 assistants and 1 runner, at least, for a doctor who's doing surgery, because you need somebody good. Oh, you don't have a runner?
No.
Okay.
What's a runner? So is that somebody who just like is seating the patients or doing sterile or?
Yeah, because I don't know how your schedule goes, but you know, you can see about 6 surgeries a day, and the doctor's going from one to the other, one to the other, one to the other. If you're having 2 assistants, so the first surgery he has that 1 assistant, and then your other assistant is probably backing them up, you know, getting them instruments that need, or you know, helping suction, whatever it is. But she's also ready for that next surgery. So when he leaves that surgery, he goes in with the other assistant to the next surgery, and no time in between. He's popping right in there. He's doing it. That girl, of course, is cleaning up that room. So it's doable. However, if you have a runner, it's somebody who's consistently cleaning sterilization, cleaning the instruments, making sure it's organized, getting stuff if they forgot, you know, a forceps, if they forgot, you know, suture holders, is the person running back and forth so that the other assistant is either prepping a patient for surgery, discharging a patient for surgery, getting ready for the next surgery. They're more clinically involved to take care of the patient. The runner is taking care of dirty instruments, clean instruments, making sure that she goes into a room where they're doing a surgery and she's taking all the old gauze away, getting new gauze, cleaning off the instruments, cleaning off all the biohazard stuff, you know, just making sure everything's clean and tidy and accessible, because sometimes in surgeries they're so busy that they're just throwing their instruments everywhere and it becomes kind of disorganized. So she's that person that while they're gloved up, she's hooking up machines, she's getting new hand pieces, and she's doing all that. Again, it's doable with 2 assistants. It depends on how busy you guys are. If you guys are doing a lot of surgeries every day, you're booked up for like 3 weeks or so, you may want to consider getting a runner, because it doesn't have to be somebody that is experienced. Our runners are usually never have been in dental, medical, nothing. They're just really looking for a career job. We start them off at like $10 an hour. They're working their butt off. They're opening and closing. They're just really working hard, and they can usually work themselves up to being an assistant one day, but not really quick.
Yeah, I think our issue is we have 2 assistants, and one of them is like she does all the surgeries. So if like we have a surgery back to back, like we're waiting on her to like jump into the next surgery too. She's finishing up with the other one.
So what does the other assistant do?
She's kind of almost a runner.
Is she experienced, a dental assistant?
So this is her. She just graduated from assistant, like her assistant dental assisting program, and so she's still kind of being trained.
Okay.
Which I think is that just may be the reason why she's not in any surgeries or like doing any of that.
So is your doctor, is she patient enough to?
No.
Okay. And that's my doctor isn't either. So I mean, most aren't. They're trying to do what they do, and they need someone who knows what they're doing to.
That's exactly what she wants. She wants somebody to know what they're doing. Right.
So my recommendation, and I've had this talk with my doctor before, her production and the schedule and the overall chaos of the office would be so much better if she can just be prepped to understand we're going to start putting this other assistant in. This other assistant needs to not be scared, needs to be ready to just buckle up and go with this, but it's probably time to start having her more aggressively trained. So usually when I'm training an assistant, the first thing I have them do is retract and suction. That is it. And I will be the one that's passing the instruments, keeping it going, mixing the material, getting the implants ready. So all they're doing is retracting and suctioning. That way they're getting a feel for the speed, they're getting a feel for the tone, they're getting a feel for what your doctor is really expecting. That's when she's going to realize the time frame to get the instrument off the table and in her hands, all that. She's going to be able to do it. And she would be doing that for a few weeks, just really taking it all in. Then once you guys feel like she's ready, then she can start being the one that passes the instruments. And then she can start working into doing both of them. Of course, the doctor has to be on board that we're going to do it slow, and it's going to take some time for you guys to have her do that. And then usually how it ends up is slowly me, the experienced one, is the one leaving the room to set up the next room while they're sitting there. But if they need me, they can call me. I'll run in real quick and help. So, and of course, starting off on small surgery, she's not going to be doing a sinus closure. She's not going to be doing, a full arch of implants, but, she can do a single implant procedure, crown lengthening, something like that. Nothing really bad like tissue grafting, because you're going to freak her out, because it's just those are the hardest one, because they bleed like crazy. So, just doing it where it's comfortable for the doctor and the assistant. But we actually just recently did that. The person that was my second assistant was my front desk girl for 3 years, and she wanted to start working clinical, and she had no experience. She's not even certified. Mm-hmm. So in the state of Florida, they can work under a doctor for 6 months before having to be certified. She's been doing it now for 4 months. We started doing that process with her. Now, remember, she has no dental experience. She is now running the surgeries by herself, and we're hitting on 5 months now. Wow. So, but it was the agreement of, listen, we're going to put her in, and the doctor had to, of course, meet with her and say, listen, this is what you did good, this is what you did bad. It's a training process, and it's really hard when you have a really good assistant that doctor loves, because she feels like she's the one being tortured through the process.
Yeah, and that's what happened. Is her main assistant actually left, and so the other assistant that kind of did help with surgeries is now the main assistant.
Right.
So now she doesn't want to put in like another new one, and so she's
Well, it wouldn't hurt to have talked to a doctor that assistant is going to leave one day too. You have to prepare yourself for those situations. It hurts a lot less if you're prepared for it. So I definitely have my first and second girl able to do a surgery, because somebody's going to be sick one day. What happens if she's sick one day?
Yeah, exactly. We don't. I don't even know what happens.
And in my office, girls don't call on sick, but it happens. My main surgical girl was 5 months pregnant. And she went into premature labor and had her baby at 5 months. That left this girl to do surgeries by herself for 4 months, and she never did surgeries before. So we were really, really in a pickle. But if you have your first and second surgical assistants that can do it, you guys are going to be so much more ahead just doing that. And then you could actually hire on a girl that was a runner, and you guys could do even more production. You guys can make it even tighter, because she'll have 2 very valuable assistants. So I would work on that training for that second girl.
Definitely. I mean, I definitely agree. I think doctor.
Yeah, I know.
Yeah,
you just have to work on her.
Her on board. Yeah, I got to work on doctor.
Yeah. But I would recommend starting with the suctioning and retracting first, and then slowly graduate her to doing that. But I always find it best that when you're training, you're still working with 2 assistants for as long as you can. Now, in the beginning, maybe you can't because someone's discharging. So have her come in when she's done, take over suctioning and retracting, having the other girl help her. Okay, well, then when it's time for the next patient to start setting up for the next patient, leave. Let the other girl be by herself, set up the room, come back and check, and then start that patient. And even come back and tell the other girl, okay, you're good to go start the next patient. Finish up, suture up, discharge, just kind of start that way, and eventually just start getting better and better and better. But I also make sure that the doctor and that girl talk every day at the end of the day, because she really needs that constructive criticism so she knows what she needs to work on.
What she needs to work on, yeah. Definitely.
Good.
Definitely. Thank you.
You're welcome. You had...
A doctor really wants to know how you guys handle patients who only want to have cleanings here and not alternate to their general dentist. Because she's really big on wanting them to alternate, and a lot of our patients, they don't want to go to two places, or they just want to stay here.
Right.
So.
Again, we have that same problem. Now, these are patients that have been referred to you by them, correct?
Yeah.
Okay. So we have that too. You know, it's a good problem to have, that patients love you, want to stay with you. It's a great thing. We tell our patients, listen, I understand and we are very flattered. I love that you want to be here. We love that you're here. But Dr. Smith referred you here so that we could keep an eye on your periodontal issue. And we are, and we love doing that. But we do have a relationship with Dr. Smith that we don't want to ruin. You know, we value him, he values us, and we want to keep that relationship really good. And because of that, we can't steal you. We'd love to steal you, but we can't steal you. So, you know, we do have that agreement with the doctor. We don't want him to, you know, to think that he can't trust us. We are a specialist. He is your dental dentist, and we are going to continue to alternate for as long as you want to, where you come here at least once a year or every 3 months, whatever it is that you do, and we see you. But we do, you know, we don't want to hurt Dr. Smith's feelings. We don't want to do that. You know, he's a great guy, and we have a great relationship. We've worked with him for a long time. And we just kind of do it like that, where it's kind of like, you know, we don't want to make him mad. You know, he's a good guy. And at the same time, we do give compliments to that doctor, whether they're good or bad. You have to do it. You know, he's a great guy, you know, and he was good enough to send you here so we can keep an eye on you. So we do have to honor that with him. And they usually go, okay, all right, that's fine. Yeah. So if it is something where they're complaining about their dentist, which that happens too, I hate my general dentist, I don't want to go to him anymore, I just want to stay here. Well, in that situation, we have to say, if you don't want to see your dentist anymore, you know, we are going to have to recommend that you go see somebody else, because if that dentist finds out that you're seeing us and not him anymore, he's going to be really upset at us. And we work with these dentists. They know us as specialists, we have an obligation to help the general dentist. And I don't want them to think that we have, you know, taken you. So I can talk to Dr. Smith for you. I can express your frustration. I'd be more than happy to do that for you, because I would like you to work that out with him, because he's a great guy. He's a great dentist, whatever it is. And try to see if you can solve that. And then Dr. Sheldon is the one that makes that phone call. He's like, yeah, Dr. Smith, I just want you to know, Jane came in here today, and she expressed frustration with the front desk, with the scheduling, that she always has to wait. She told us that she wanted to stay here. We told her, listen, you've got to go back there. You know, he's a great dentist and he's taking care of you. But I did tell her that I would call and express her concerns. And I told her she couldn't stay here. And that way the dentist knows that you have their back and that you're looking out for them. So definitely would keep doing that for them, so that they don't, because if they do find out they're coming there, boy, they get mad. Oh my gosh, it's so upset. So we do tell them it's our obligation to them. We can't step on their toes. I'd love to keep you, but we can't keep you.
Okay, perfect. Yeah, she likes to tell them, you know, that it's better for them and their care for them to have as many hands in their mouth as possible. We're not restorative dentists, so, you know, we're looking on the periodontal side, not on the restorative side, and that it's very important that they go to see their general dentist.
Absolutely. And they usually understand. Dr. Sheldon always makes a joke with it, because it's always better to handle the laughs and the grumps, of course. But he always says, man, I'd love to keep you. You kidding me? We'd love to, but no, I'm not going to have Dr. Smith mad at me. Heck no. You're going back.
Yeah. No, definitely.
Good.
I like that.
Good.
Perfect.
And what else did you have? Anything else?
Just like the financing options for the patients. I don't know if you guys have anything other than care credit.
Oh, yes, we do. If you have a pen, I have information for you. The number one second choice, other than care credit, is we like Lending Club. You ever use them?
No, I've never used them.
They're amazing. They actually finance up to $40,000.
Okay.
Actually, is it 40? Yeah, $40,000. They have great interest rates, and they're really easy to work with. It's called Lending Club. It's 1-888-596-3157. The other one, I would give you their information, but I can't recommend them because I don't know if they're good or not. It's a company called Lending USA. Now, they have contacted us over the last 5 months. They claim to finance those who have lower credit scores. We have actually tried to use them twice, and we didn't. It was just, hey, we have time, I'll go ahead and try them, and we were not able to get the patient accepted. So maybe the patient just had a really bad credit score and they just couldn't do it. But we just kind of stopped using them. But the only reason why is we have 2 good ones, Care Credit and Lending Club. We don't really need a third one, but I would look into them anyways. It's called Lending USA. It's 1-800-994-6177.
Perfect. And with the Lending Club, how does that process to get them approved for
It's very similar to Care Credit. Nope,
Okay.
You do it in the room, just like Care Credit. It takes like 5 minutes. They give you the approval, and you can process it right there.
Okay.
Very easy.
Perfect. Yeah, because I think I've heard of them before, but I've never used them before. I always used Care Credit.
Yeah, I've noticed them recently at some of the expos and such, but I think they're just a newer company, but we've used them for a year. Yeah. Yeah.
And the patients seem to have like a good.
Oh yeah, we have no problems, and I think it's been more than a year. And I'll correct myself, about more than 2 years we've used them. No problems expressed by the patient. Nothing.
Well, I hope that was able to provide you with some solutions to some possible barriers. If you don't think that you're having these barriers, definitely ask your staff because they may have heard these, they may encounter these. So these are great webinars to share with your staff during a staff meeting because I guarantee you they've gone through this a few times.
It's true, and doctors, the same thing. I mean, contact me. You've gotten it from Danielle's perspective. Obviously, some of the things that she says I do, maybe I do, but you may want to hear it from my perspective as well. So just send me an email. Let me know if there's any particular questions you have in that regard as well.
Yep. And thanks for joining us as always.
That's right.
Any questions or concerns, give us a call or email us.
We can say Happy New Year.
Happy New Year.
Yeah, it's good. Have a great one. Bye-bye.